For this lecture, we will discuss Chapter 9, Compatibility Testing. So in the world of transfusion medicine, compatibility testing involves all the steps that are used in the identification and the testing of a donor unit, as well as the possible recipient that will be receiving that donor unit. Now, cross-matching is part of the actual compatibility testing. So this involves mixing the actual donor red blood cells with the recipient serum or plasma and checking to see if you have any indication that there's any sort of compatibility or incompatibility. So no agglutination or hemolysis would indicate that there is compatibility, where agglutination and hemolysis would indicate that there is an incompatibility. So when you're actually doing the resulting for this testing, you're going to determine that the unit is compatible or that it is incompatible. So that's how you will actually result that unit as compatible versus incompatible. So that's what we're looking for, is compatibility and incompatibility in the world of transfusion medicine. Now the purpose is actually to do the cross-match. The purpose of it is to serve as a double check to look for any possible ABO type errors that could have occurred, because that's going to be your quickest, most severe transfusion reaction that's going to take place if you have an ABO incompatible unit, if you give the complete wrong blood type. And it also provides a second means of being able to detect any kind of antibody that you may have not detected while you were actually doing the pre-testing or that type and screen, that antibody screen. So just in case you missed anything there, this should be that extra check to determine if you've missed anything or made any errors. Now, according to the AABB standards for cross-matching, a cross-match shall use methods that demonstrate ABO incompatibility and clinically significant antibodies to red cell antigens, and shall include an antiglobulin phase. So there has to be some sort of antiglobulin phase within that testing. So this is usually going to include that actual antibody screen that takes that recipient all the way through that antiglobulin phase, looking for any potential antibodies that are present. And that allows us to be able to do that pre-screen to see if there's going to be anything that could potentially cause any problems. Okay, so this is a pretty busy page here, so let's kind of run through this to kind of see the various steps that happen within the transfusion world when an order is placed for blood or blood products for a patient. So first off, the first step that's going to happen is the sample has to be collected. So the phlebotomist or nurse or whoever is responsible for doing that collection will actually confirm the identity of the recipient. So you'll do the checks that happen with those pre-transfusion or pre-analytical steps where the sample from the patient is actually being collected. So whoever's responsible for this, like I said, phlebotomist, nurse, assistant, medical assistant, whomever is trained to do the collection. And so what they're going to do is confirm the identity of the recipient. So there's usually some kind of armband, photo ID, some sort of identification that's going to happen to make sure that that patient is who they are. But most places it's going to be some kind of identification bracelet that is going to be used for that identity. And then what the phlebotomist will do is actually collect the specimen and then accurately label that specimen, that pre-transfusion specimen, with the appropriate labels. So most facilities will, if there is a potential for a cross-match or transfusion, so just even if they're going to do just a type and screen, they are going to do those blood bank bracelets. So they'll put those on there, which is just an extra identification number for that blood product that's going to be the identification for that pre-transfusion tube. So that tube that was collected for this particular patient at this particular time. So it's going to get its own blood bank bracelet, and they're usually colored by some means, red, yellow, green. I've seen a variety of colors for these blood bank bracelets, so it's just whatever the facility chooses to use. Now, once that sample gets to transfusion services, they're responsible for the testing from that point on. So transfusion services will get the recipient's or the patient's sample to do the actual pre-transfusion testing. So once it is in the blood bank world or in transfusion services, however it's termed within your facility, they will actually go through several different processes. And so those processes are going to include things like reviewing the patient records. So we're here. They're going to review the patient records, look for any kind of historical records of any kind of indication of problems or special notes or anything like that that may be involved with that patient, as far as if there's previous antibodies or previous notes to always transfuse leukoreduce because of a transfusion reaction in the past, whatever notes may be in there. You may see that they were just transfused in recent days or months. So this is all information that you'll want to be aware of while you're doing the testing. Also, you may see notes in there if there were anything that they need, that previous techs had to do to resolve any issues. For example, maybe if it was an elderly patient and they had to incubate the sample at refrigerated temperatures in order to enhance those reactions for that ABO type. So anything like that, you're going to look in your system to see if you have a history on this patient. If you don't have a history in your system, you're just going to assume that that there's nothing in your facility, but you can't really rule out the possibility that the patient was transfused somewhere else. So because you do not have that history, you're just going to kind of have to work off of what's before you. Sometimes, depending on what you run into, you can get more information from the nursing staff and have them actually ask the patient if you need more details. Also in transfusion services, the donor units are actually checked into inventory. So this is usually a step that is done before you ever get to the point of cross-matching those units with the patient. So this is either going to happen, some of these steps that happens with the blood supply are going to happen at a blood supplier, so something like the Red Cross or whatever blood services may be available in your area. Or if you are a facility that actually does the collection of blood products and processes those, then this may take place at your facility, so you may participate in this. So this process that the blood supplier will do will be actually performing the blood types of the products, labeling the products, doing all of the testing of the product, doing blood type antibody screen, looking for any sort of infectious disease, labeling that product, and then shipping it to the facility that needs it. If you are a site that has a donor center on your site or on your campus, then this would be actually something that would take place at your facility. But one of the additional steps that has to be done anytime blood products are received into a facility, so whether you do the collection at your site or whether it comes from somewhere like the Red Cross or another blood center, then once it gets in your hands in the transfusion services, you are responsible for doing what they call a recheck, a donor recheck. So you have to recheck that blood type before you put it into your inventory, just as a safe protocol to make sure that there wasn't errors that happened before it ever got to you. So you will do a donor recheck, looking for the blood type. So you're typically just going to do an A and a B. If it's an O, you could screen with anti-AB, but you're basically just going to be checking that type. If they are Rh negative, then you would just run an anti-D just to make sure that they really truly are D negative before you put that into your inventory. So you're going to do all the checks that you've got to do to put the unit into your inventory. It's going to include, when you receive it, recording temperatures, making sure the product looks good. You're going to visually inspect it, make sure that it's labeled properly. So there's several checks that you will have to do when you receive blood products before they ever go onto your shelf. So typically this is going to be done once you get it to your facility. You're going to do this step. You're not going to do it just randomly throughout a cross match. Typically this will already be done when you're ready to do to actually select the unit to do the cross match for transfusion. Now, once you've done all of your testing, so in the blood bank you are responsible for doing the blood type and antibody screen for those patients before you actually do that compatibility testing. So this is what facilities will call a type and screen. And so that's just doing the blood type and the antibody screen. Now that testing, so we're going to kind of break this down here as far as making the decision of once you've done all of these first few steps, once you decide, okay, I'm going to select the units, then there are a few things that you've got to be sure of first. So when you get that type and screen requests down, from there you're going to do your blood type and then your antibody screen. Now based off that antibody screen as well as your history, because you're always got to keep that history in mind as well. So when you're looking at that history, you're trying to see, did they previously have antibodies or anything that you need to pay attention to and be aware of. Now just because an antibody screen shows up negative at this point does not mean that if the patient previously had, let's just say, the patient previously had an anti-JKA, because we know those kids like to hide and play games and all of that. So if the patient previously had an anti-JKA in the history, but it's not showing up now, you still have to honor that. So this is where this comes in here. So let's just run through each of these. So if you do the antibody screen now, patient has no allo antibodies, so that antibody screen is negative, then you don't need to do any kind of additional testing. So that just means you don't need to do an antibody workup. So you can perform an immediate spin or computer cross match. So this will just be dependent on what your facility does, as far as if they do immediate spin cross matches or computer cross match. Then you would select those units based off the type, things like that, and then either do the immediate spin or do the computer cross match. Now, if your patient has an allo antibody, so in other words, you did that antibody screen and it is positive, then you got to work it up. You got to figure out what that antibody is. And then you're going to perform a cross match, which is going to include immediate spin and antiglobulin phase on the units that are antigen negative. So if they are antigen negative, that means you have to actually do antigen typing. So when you do your antibody workup, part of that will be to actually do the antigen typing of your patient as well as your units, because we need to verify, so our patient is just kind of like our recheck, or how we do ABO in reverse. Antigen typing our patient to make sure that they are antigen negative for that particular antibody is going to be your confirmation. If they are not negative, you need to do some investigation. Maybe they were previously transfused at another facility and you need to contact that facility and get that history. So that's what you're going to do if there is an antibody present. You're going to work it up, you're going to identify it, and you're going to honor it. Now, if you do look up in the history and you have a record of a previous allo antibody, even if it's not showing up now, then you need to honor that. So most facilities now have put into place, it used to be in the past, most facilities just honored it. As long as the antibody screen seemed to match up with it, they honored that antibody, did the full cross match, and then if something didn't match, then they would work it up. But now a lot of facilities have put into place that you've got to run a panel every time you get that positive antibody screen, just to confirm that the antibody that's in the history is what you are still seeing and that it's not anything new. And of course, you're going to do the same thing you would if you had an antibody here, where you're going to honor that antibody, you're going to give antigen negative, and you're going to do that full cross match on that patient. All right, so back down over here. Once you select the unit, so you're going to do a type compatible, and we'll talk about that here shortly. And then from there, you're going to make sure that you tag that unit. before you issue it, you're going to inspect it to make sure that there's no sort of contamination or issue or anything like that. And then the medical staff that is requesting that unit. So typically the nurse is going to come down and request that. Your facility will have some sort of policy on how they make that request, whether you have any kind of paper trail tied to it or if everything just goes through the computer. And then once the nurse starts that transfusion, they have several checks that they have to do. So it's usually 2 individuals that are involved of reading off the patient's bracelet as well as that unit to make sure that everything matches. And there's several checks that they have to do before they ever request the unit, like checking the patient's blood pressure, checking the patient's temperature, things like that, just to make sure that the patient isn't having any issues before you start that unit, because you don't want the patient to be having issues and then not know whether it's the patient's health condition or whether it's the actual unit that's caused the problems. And during that transfusion, there are intervals in which the patient has to be observed. So it's within a certain amount of time after they start the transfusion, about 30 minutes in, and then an hour, and every hour after that. I think it's 10 or 15 minutes into the start of that transfusion. And another thing to keep in mind, when they hang these units of blood, it's actually got a line that's running. So once they hang that unit of blood and they open it and becomes an open system, so they actually puncture into it, and then it usually joins in with some sort of saline as well, a little bag of saline that's hanging up as well. And but when you start that timing to watch that transfusion, it takes a little bit of time for that blood to actually travel through that tube and then actually go to the patient. So one of the things that you have to do is just make sure you're observing that line, that you're not starting that time interval until it actually starts to enter the patient, because this could be 5 or 10 minutes, and that you're watching this go through this line. It probably really doesn't take that long, just a few minutes, but it takes a little bit of time for it to travel through that line. So once it gets to the patient, that's when your timing actually starts, and then you observe. Like I said, it's either 10 or 15 minutes in, and then you have like a 30-minute interval, and then it may be every 15 minutes for like the first hour or so. But once it actually is infused, starts infusing in the patient, that's when you start that time, because you want to make sure that the patient's actually exposed to the product, and then you're observing for any sort of potential reaction that the patient is having. So we will talk about some of these reactions and things once we get into our adverse reactions for transfusions. Now, determining which particular cross-match you're going to do, it's going to partly be dependent on the facility as to whether or not you do a computer cross-match, because some facilities do this now. But basically, you're going to make this determination based off of everything that you have done in your pre-transfusion testing. So if you've decided that there's no evidence of clinically significant antibodies, so in other words, your antibody screen is currently negative, and the history, there's no kind of major issues based off the history, no previous antibodies in the history or anything like that, then you can just do that immediate spin cross-match. Now, if you do have evidence of any sort of antibody in the past or currently, so you've got that positive antibody screen, then you will need to honor those, which means you're going to have to do that anti-human globulin cross-match, or take it all the way through that AHG phase. So you will go through all 3 phases of testing. If you're using a system like JAIL, of course, you know that it skips those first couple of phases. It doesn't really skip them, you don't record them. So when you're doing your anti-human globulin full cross match, this is what we term a full cross match. When you're doing that, you should always, the standards really kind of recommend that you should use whatever you use to do your antibody screen with should be what you should use to do your full cross match with. So in other words, if you're using the gel system, then your full cross match should be in gel as well as the antibody screen. If you're using tube method, then your antibody screen is done in tube method. It should be done in tube method for your full cross match as well. Some facilities may not be able to do this, so they may do the full cross match in gel and then still do the tube testing. But just keep in mind, it is recommended that whatever you use to do your antibody screen, you should do the full cross match as well. Now, computer cross matches, these get a little hard for me to stomach just because when I did cross matching, I did cross matching in tube, so I always liked that immediate spin cross match. I think it just kind of helps give that extra check. So, but I know a lot of facilities, just to save time and things like that, they do use computer cross matches now. And with that, there needs to be, again, you've got that negative antibody screen as well as no history of antibodies. And then there has to be 2 ABO type of determinations that are performed. So this is where making sure that you have verified that blood type of that donor, that recipient multiple times, as well as that donor's then been through all of its proper checks. And then the computer system has to go through a validation procedures to ensure that it will not allow an incompatible product to be assigned. And you will have to maintain proof of this at your facility, that those validations were done on that computer system to ensure that an incompatible product is not issued in error. Okay, so let's talk a little bit more about those cross matches. So an immediate spin cross match is performed when the recipient has no evidence of an antibody. So this is the current or historical. That antibody screen is negative. History is negative for antibodies. The recipient's serum and the donor red blood cell suspension are mixed. So remember, if you're transfusing a unit of red blood cells to a patient, so you've got that unit of red cells, you're actually testing a bit of that segment, and I'll show you a picture of that at some point where you have those segments attached to that unit. And so you're going to take one of those segments off and make you a suspension, and then that's going to mix with the recipient's plasma. So you're going to put that in the tube. So you're going to put those drops of the recipient's plasma, and then you're also going to put that drop of that red cell suspension that you make. And you're going to mix it up, centrifuge it, record those results. And of course, you're looking for any sort of positive agglutination reaction, as well as any sort of hemolysis that could be taking place. And so this will actually meet the standards for looking for any sort of ABO incompatibility. For the antiglobulin test, of course, it goes through all 3 of those phases, where you do an immediate spin, 37°, as well as the anti-IgG phase. And so you're going to do this if there's any sort of history of problems, or you have found an antibody, there's a history of an antibody that's present, and so you need to do that full cross match. If the patient has an autoantibody, then an auto-absorbed serum can be used to actually do that testing. Again, this will depend on the facility that you're at as to whether or not they're going to actually work up patients that have issues like this. So it really will be a facility call as far as how they will handle certain situations. Okay, and you also have a computer cross match, and so this makes a final check of the ABO compatibility in the selection of the unit instead of doing that immediate spin procedure. So the recipient must not have any antibodies present, history, or in their current sample. And then of course you have to use the barcodes to provide a way of a safety measure. So barcoding will actually keep you from doing any sort of keying clerical errors. Now there's a table that's listed here that goes over what the requirements are to do a computer cross match. So again, I mentioned that the computer has to go through a validation process for all of your components. There has to be 2 determinations of the recipient's ABO, so you have to have it off the current sample, as well as you have to do testing off of a second current sample, or it has to match the historical record. So a lot of facilities will put this into place, not just for computer cross matches, but just as another safety measure. They'll do a blood type repeat, or there may be other names that facilities may use for it, or a recheck, something like that. And what they'll actually do is, if they put the patient, they do the patient's history and it's no type on file, then they'll enter that blood type. If it's any type other than O, because if it's an O patient, you're going to give them O anyway, which is kind of, you know, considered your universal. So if they're another blood type other than O, then you would order that recheck and get a second stick. Some facilities will actually use, like if there's a CBC that was stuck at a different time, they'll actually use that CBC sample to do that blood type recheck, and it just saves the patient a stick. The computer system includes donor information, so it's going to be information on the product itself, including the blood type, those unique identification numbers, the fact that it's been ABO confirmed once you got it in your facility, so you do that ABO recheck on that donor unit. The computer system will have two ways to uniquely identify the recipient, and so it's also going to include the recipient's blood type and their Rh phenotype, the antibody scheme results, and interpretation of any sort of compatibility. The computer system has to have a way to alert you that there is an ABO incompatibility, so that's going to be part of that validation, to make sure that those alerts are flagged and that the staff is alerted anytime there's the improper product is selected. And there is a method to verify the correct entry of all data before it's actually released, and this is where that barcoding actually comes into place and is real handy. Now, with pretty much any procedure within the lab, there are limitations. So just having an acceptable cross-match alone does not guarantee that the transfusion itself will be successful, because you still have the potential to have adverse transfusion reactions. Just because the antibody screen is negative does not mean that that patient doesn't have any kind of significant underlying antibodies. It may just be that it's not detected. Remember, those kids will tend to kind of fade out and pop back up whenever they feel like it. And a compatible cross-match does not guarantee the survival of the red blood cells. So just because you get compatibility on your cross-matches does not mean that once they enter that patient's body, that the patient will not have a response and then ultimately end up destroying those red blood cells. So there are still some limitations. You do everything you can to try to provide that safe product, but there are still things that can happen that are beyond your control. Okay, so just a few notes about the recipient's blood sample. So once it is collected, there are some rules that must be followed. So for patient identification and sample labeling, so when you're doing that identification of the patient at bedside, you have to have two identifiers. So it's typically name, date of birth, or you're also looking at the bracelet and looking for the name or the medical record number. Most phlebotomists entering a patient's room will ask the patient to state their name and date of birth, and then they will verify that information on the bracelet as well. Now, again, I mentioned with blood bank, they're usually going to include an additional identifier, which will be that blood bank bracelet. Sample collection too, so the sample has to be plasma or serum. Most places will use plasma now, depending on where you're at and what testing needs to be done. So if you're doing some of those auto absorptions and things like that, you may have to do serum as well. If you're sending samples out to another facility for them to work up something, they may request serum as well as plasma. So whatever testing you're going to have to do, just make sure that you're aware so that you know what sample to send. Now, the age of the sample is important. 3 days on that sample if the patient has previously been transfused or pregnant, and that's just that 72-hour rule. 3-day, 72-hour rule is because the potential for someone to make antibodies after being exposed to any sort of antigen. So that could be through transfusion or through pregnancy. Sample collection and appearance. So you want to make sure that that sample is not hemolyzed, because remember, hemolysis is a type of reaction, so we do not need any sort of false results hindering our interpretation of our results. Samples should not be contaminated with any sort of IV fluids, because those IV fluids are obviously going to dilute that specimen out. And I will make a mention too, it doesn't say it here, but clotted samples can sometimes cause issues. There's a little bit of fibrin that you can start to see if a sample's clotted. It's not necessarily a rejection, so depending on your site, they may or may not get a clot recollected. Most places aren't, because if you're using serum, you're going to have that clot in there anyway. But just kind of keep in mind, if the specimen clotted during collection, then sometimes you can see a little bit of fiber fragments, and that can sometimes give you a false impression that it's clumping when it's really fibrin. And your samples that are old, so if you're holding on to a sample, let's just say a patient was doing a pre-surgical workup and the sample was collected a few days in advance of that surgery. Once you put those samples in the refrigerator and use them after they're a week or two old, then you can start seeing that fibrin form in that sample, and you can see that when you're doing your testing as well. So make sure that when you're at your sites and you're going through clinical and things like that, that you are asking them of what some of these things are. Ask them what fibrin looks like in your testing when you're doing testing in tube, just so you're aware of what fibrin actually looks like, because it can make you think that there's an actual clump or agglutination that's taking place. Looking at those previous records is very important. So when you get that sample to the blood bank, one of those first things that you're going to do, probably while you're spinning the sample down, checking the label and things like that, making sure it's properly labeled, making sure your sample's good, is you're also going to be doing a history lookup to see what type you have on file, if you have a type on file, has the patient been transfused, and you're going to make sure that that what you're currently getting is matching that historical file. And of course, you're looking for any pertinent information like special notes on that patient, any kind of history of reactions or antibodies or anything like that. Okay, so repeat testing of that blood unit. So this is where I mentioned that once that unit gets to the facility, then you have to actually do a retype of that unit just to make sure that it's properly labeled. And so what you'll do is actually just do an ABO. So you could, if it's an O unit, you may use anti-A, B. If it's, most places are just going to do your A and B anyway. It's easier just to go ahead and set up all your testing for the A and B, regardless if it's an O. And then if it's an anti-D, you're going to make sure that it's D. You're going to do an anti-D tube as well, or whatever your method is for checking it. Weak D testing is not required, because if you've got D on that immediate spin, it's just confirming that it was labeled properly in the testing facility, or the donor center for that facility or whatever is going to actually do the weak D testing as part of their workup when they're doing that donor testing. Now, records for your donors or your units have to be kept for 5 years. That's just kind of a little side note there. But I mentioned earlier about these segments. So you can see here where you've got this segment that comes off of this unit. So this part of it is still an open system. Now, if you look real close, right here, you can kind of see where there is some numbering on this bag. So you can see it there, you can see it there. So it's usually a series of letters and number that are unique to each individual bag or collection set. So there are additional bags. So remember, it goes through that process of your whole blood, and then you spin it down and you get your plasma products off of it, and you can make your plasma products. you add your adsol or whatever additive to this red cell unit. So this particular one, I think it says adsol down there. And so then you get your red cell product. Well, that tubing where it run through that leukocyte reduced filter, or whatever tubing where it ran into the actual bag, so that's sealed off. That tubing has that unique number. All of the additional tubing that was attached to this product has that unique number. And so you can see here, this right here, this set of segments, actually I think it went, this is probably this is the end that comes from the filter. But each of these segments here, you can see where they've kind of been sealed off. So that tube welder that we talked about in previous lectures, I think you had some videos on it, you may have had an assignment, it will seal those off. So you would actually go through, there's little marks on this tubing, and you would go through and seal it off at those marks. That way each of these segments has that unique number on it, so that if this ever gets, because sometimes you can burn through these and you can disconnect them, but it gives you a way to verify. So if you ever have one that's loose and you're not sure what unit it come from, you can compare that number against the actual bag itself, or the number that's on that tubing that goes into that bag, just to confirm that it is with the right unit. So that could be some of your troubleshooting that might have to take place. But the segments themselves, you will pull one of these off, and then that's what you would use to actually do your testing for your blood type, your retype, or if you're doing your cross match, then you would use one of these segments to actually do that cross match testing. And there's usually several on there, so you have enough to do multiple cross matches. So if you cross match for one patient and it's not used and you put it back into inventory, then you could test it for an additional patient. So just to recap, that pre-transfusion testing is going to include your blood type. Discrepancies should be resolved. So if you have any sort of ABO incompatibility or historical discrepancy, you've got to resolve that. You're looking for antibodies, so you're doing that antibody screen, using those pooled red blood cells, those reagent red blood cells to detect any sort of antibody that might be present. And of course doing that cross match, whether it's computer, immediate spin, full cross match, whatever it is, based off of your results. So this is what's all going to be included in that pre-transfusion testing, as well as looking at that history to make sure everything matches up and there's no issues. Now, selection of your units are going to be based off of a few things. You're looking to determine, number one, what the blood type is. So based off of that phenotype, you're going to match up red cells with that blood type. If you're giving whole blood products, you've got to match the type exact. And that's because you remember you have that plasma that's in that whole blood too. So you would be given antibodies. So you got to make sure that you've got to match it completely when you're doing whole blood. Red blood cells, you can do it based off the type, and then your plasma products has got to be based off of what antibodies are present. All right, so if you're looking at the D antigen, so you're matching blood type, and then your D antigen, your D antigen negative units are going to be given to just your D negative recipients. So this is going to be especially honored with women of childbearing age. Antigen negative blood should be given if anti-D antibody is formed. So pretty much you're going to match up your RH type with your recipient. There are some cases where, let's just say your O negative inventory is very low. This happens a lot. You may only have like 4 or 6 units left, so you're trying to reserve those for those women of childbearing age because you don't want to induce an anti-D, and you're also trying to conserve it for your patients who already have a known anti-D. And so in those situations you might have to do some deviations from standard policy, where of like your men, you might give them RH positive units with the idea that you could potentially stimulate an antibody. But when you're in life or death situations, sometimes you don't have a chance. If your inventory is low and you've got a male that's bleeding out and you're going to have to give a lot of products, you might have to kind of sacrifice and get your pathologist to make that call to give some of those Rh positive units to those male patients, just so you can conserve for your anti-D patients and your childbearing females. And that's just because those childbearing females could potentially make an anti-D, and then you're causing issues for her in the future and future pregnancies. And of course, if you have a recipient that has an antibody, you're going to have to give antigen negative units, especially for, of course, that Rh system, the Kell, the Duffy, the kids. Really anything could potentially cause issues, but definitely those ones that are associated with those hemolytic transfusion reactions. So your textbook does have this nice little chart that goes through some various scenarios of problem solving of different scenarios that you might have and what could be the possible cause. So for example, your antibody screen is negative, but you do an immediate spin cross match and you've got a positive reaction. Well, maybe there was just some sort of the donor cells are ABO compatible. Maybe you picked up the wrong unit and didn't realize it, or maybe you got some other things that are going on, like a cold antibody or rouleau or things like that. And it even talks about a scenario, which let's hope you don't run into this, where you've actually got a positive antibody screen. You can't find compatible units. Everything's incompatible. Your auto control's positive. Your DAT's positive. Sounds like you've got a hot mess going on here. So let's hope you don't run into this, because if you do, you're going to have to go through a lot of different steps to go through the process of troubleshooting and making sure that you can find compatible units. Because it may be a situation where you've got something like the presence of a cold and a warm auto antibody. I've seen patients with both cold and a warm at the same time. Don't ask me how it happens, but it happens. And when you get situations like this, you really, if the patient is really in need of blood, you kind of have to go through all the process, give them antigen negative for what they could have an antibody to. You go through doing the various absorptions and things like that, and you basically get the safest product possible and hope and pray for the best outcome for the patient. Because when you look at it in a tube test, it looks like that it's not going to work. So, but when you're at the point that the patient is in a dire need of an actual transfusion and they're having complications and they need that unit of blood, you're just hoping that the benefit outweighs the risk in that particular situation. Okay, so once you've actually done the steps that are required to do the cross-matching and making sure that that unit is compatible, then you have to go through a process of actually tagging that blood product for that recipient. So there are specific requirements that should be on the tag once you've done that cross-matched, got that unit cross-matched and ready for that recipient. So on that unit, there is usually some sort of tag that's placed on it. And so that's going to include the patient's full name with those two unique identifiers, so date of birth, medical record number, usually that unique number that's on the donor unit or blood bank bracelet is going to be included as well. The name of the product has to be on the tag, so whether it's fresh frozen plasma, leukocyte reduced red blood cells, whatever the product is, it has to be on that label. The unique donor number or the pool number, so whatever that number is, that ISBT blood product number, so it's usually a W or something, and then it breaks it down to the year, and then you have so it starts off with the facility, then the year that it was collected, and then the actual unit number. The unit's expiration date as well as the blood type has to be on that label. And then the interpretation of the cross-match, so compatible or least incompatible. Occasionally you might have to use one that says least incompatible with that situation we were explaining on the previous slide. And then also the person that did the testing, so usually their number or initials or something has to be on that tag as well. Now the requirements for issuing a unit of blood, so once you've gone through, you've labeled it, you've got it in the blood bank, it's ready to go. It does require a physician's order. Again, those identifiers are very important. So making sure that you check those identifiers, so whoever is coming to pick up the unit of blood, or whether they send some sort of request slip or something through the computer, they have to send you those identifiers as well. You also have to make sure that you recheck, have some way of rechecking and confirming that you are issuing the correct ABO type as well as the RH type. Now that requisition form has to, whatever it is, so that request from the nursing floor, whatever, OR, ER, wherever, it has to include the patient's name and the product that they are requesting. They have to tell you what they're requesting, because you may have multiple things set up on that patient. You may have red cells, fresh frozen, and platelets, and cryo, and ROGAM. You could have a variety of things set up on the patient, so you have to know what they're wanting to give that patient at that time. You have to compare that requisition with that actual tag that's on that donor that you've placed on it. You're making sure that that you're comparing that tag that's on that actual unit with the product label. So you're doing all of these checks. You're looking at things like the expiration date. You're looking for discoloration, clots, any kind of abnormal appearance for that product. So you're given a visual inspection, and you're actually documenting that somewhere that you performed that visual inspection. Now, documentation of the person issuing and the person receiving the blood, the units. So you have to have some kind of documentation that you issued it. So whether it's in the computer, signature on that requisition, somewhere you have to document it that you are the one that did the inspection and issued it, as well as the person that is requesting it. They have to have signed for it as well, because they're basically stating, yes, I'm ready to give this product, I'm here to get it, send it to me, let's go. So they've acknowledged that they're at the point of ready to give it, because you have that short window for these products to be transfused. Any kind of special requirements have to be included on that label, or you have to let the nurse know. So let's just say, for example, you're issuing platelets that have not been leukoreduced already, but there's a request for leukoreduced platelets, then maybe you have to issue the filter. So or let's just say it's a patient that has a cold antibody of some sort, and it's recommended that the unit be used with a blood warmer, so it actually warms that blood as it's being infused to reduce any sort of agglutination or response due to those cold antibodies. And you also have to include the date and the time that you were issuing that unit, as well as where the unit is going. So if it's being sent to the ER, it has to be documented that it went to the ER. Now, there are some situations where a product may be issued and for whatever reason it can't be started, it's not transfused, and it's returned to the blood bank. So there are some stipulations about returning blood to your transfusion services and reissuing it. So if you say, let's say for example, you send up blood for a trauma, so it's usually going to be released in a cooler that has ice packs in it. There's some kind of temperature indicators on those units to make sure that temperature is maintained. And so situations like that, if it's not used, so they call for a trauma, you would take the cooler up, it's not as severe, there's no serious bleed, they don't need those units, or they can wait for compatible blood, then you would get that cooler back and put those units back into inventory with making notations that the temperature was maintained. Now let's just say you have another situation where the nurse comes down, requests the unit of blood, gets back to the floor, and by the time she gets back to the floor, something's happened with the patient. They coded, or radiology came and took them for a procedure, and so she gets back to the floor and she's like, hey, I can't give this unit. Well, as long as she returns it within 30 minutes of you issuing it, so that time that you documented when you took it out of the bank to issue, then you can safely put that product back into inventory. Your facility may have additional protocols that they can use, as far as maybe that there's some sort of temperature indicator on that unit, or you issued it in a cooler or something like that. So there could be other stipulations as far as the time frame that you issue it. Most facilities will also have something in place that, let's just say it's been greater than the 30-minute time frame, and so if it's greater than the 30 minutes and they call you and say that there's an issue with the patient, you know, I got up here and there was something going on, and whatever, and I've not been able to start this blood product, I don't know what to do. You know, let's just say that the nurse gets back to the floor, and she or he had another patient that coded, so she laid the unit at the front desk with the secretary, ran the code, and then comes back to try to start that unit of blood for that patient that she come down and requested on, and realized that, hey, it's like 45 minutes later because I've been dealing with this, and calls the blood bank and says, I couldn't issue this unit of blood and it's been more than 30 minutes. What do you need me to do? Well, there are rules about, most facilities have a rule that once a product is issued, you have 4 hours to actually infuse that product. So as long as the patient doesn't have any major cardiac issues or anything like that, usually they can get a product in within a couple of hours. So depending on the rate that the physician sets for that infusion, most of the time they can get it in 4 hours. So what you would just have them do is just say, as long as you infuse the unit by, let's just say you issued it at 1 o'clock in the afternoon. So you let them know that as long as you issue it by, excuse me, I almost made a mistake there, 5 p.m. As long as you've got it infused by 5 p.m., you're good to go. So most of the time you can keep from having to dispose of that product. Now, if it was a situation that, let's just say it did set out for 45 minutes and for whatever reason they could not start that unit, if your facility doesn't have a particular policy in place of what to do with that, more than likely that unit's going to get tossed. Emergency release. So this is when you have a request for blood that you've not actually done the compatibility testing on, or some sort of testing on that product hasn't been done, but the physician deems that it's an emergency situation, so they're willing to sign to say that the benefit outweighs the risk. So they will sign that paper to say that they feel that the patient's life is in jeopardy without receiving this product. Now, the unit that you're requesting, that they are requesting that emergency issue on, just means that the compatibility testing or some sort of testing like an infectious disease testing has not been performed, and so the physician's willing to take that risk. You still have to identify the patient, so you've got to know who the patient is and with, you know, some sort of identifier on that patient. You have to have some kind of policy in place of how you're going to keep up with this information. So there's usually some kind of document that your facility will use to record all of this information, so that once you get a sample, then you can kind of go back and backtrack on some of these things. But you at least need some kind of identification for that patient. Now, if you've got a patient that comes in as like a John Doe or a Jane Doe, and they don't have any identification on that patient, you're just going to have to run it like that. So your system, that patient may stay as that John Doe or Jane Doe, just to indicate that they have no identification on that individual, just until they're able to resolve that. Because you may have a situation where there's a vehicle accident and the patient does not have any sort of identification on them, and I've seen situations where cars will roll up and dump gunshot victims off in front of the ER, and they will leave, and so there's no identification on that victim, and so you basically have to give them a John Doe or a Jane Doe identification until you can get that squared away. But in that process, you're going to keep up with what units were issued to that patient. You're going to maintain that segment in the blood bank so that hopefully at some point you can get a sample and do the cross-matching. You're going to keep up with what products you issued, whether it's FFP, plasma, blood platelets, red cells, whatever it is, and as well as you're going to keep all the information on that unit, including expiration date. And usually this is going to be in your computer system as well, but you'll have some way to document all of this. And then of course you've got to have some way of documenting that you issued it, when you issued it, because a lot of times if you're just doing an emergency issue and there's no patient information to tie that unit to, you're going to have to document everything on like a downtime sheet, because you really have, depending on your computer system, your LIS that you use, there may not be a way to actually document it in the computer. A massive transfusion protocol. So this is basically when you've replaced the total volume of the recipient in a 24-hour period. So there's usually a number that your facility will use to indicate what that is. So like 8 units, 10 units, whatever it is that your facility comes up with, that once you've infused this much, then it's considered a massive transfusion, because you've basically replaced everything that is in that recipient. And so this could be a situation where you've given a bunch of group O Rh negative units, so O negative units, due to an emergency. If it is a D negative unit, if D negative is unavailable, then you might have to give Rh positive, so O positive. And so this is going to be anybody that's not of childbearing age. So this is where I mentioned earlier, those men, or it could potentially be females that are elderly. Now that childbearing age, that's kind of a wild card there, because there could be women in their 50s that are actually still childbearing. They still have menstrual cycles, and you know, they could be going through process of menopause and skip a couple of months of a menstrual cycle and then have one, but they are still fertile. So this is how women in their 50s do sometimes come in pregnant. So your facility will list what they consider a childbearing age. ABO identical units can be given once you've actually established a blood type, but so let's just say you're in a trauma situation and you're issuing a bunch of O negative or O positive units. Once you're able to get that blood type, then you would actually start issuing type specific blood instead of actually doing that cross match. So you reach a point where you've basically wiped out their own red cells and you're replacing it with just whatever you have. And then some facilities will have a protocol in place where you actually, after a certain point, you just stop doing the cross matches, because you're not even cross matching with the patient's blood anymore. Maximum surgical blood order schedule. So this is just kind of an outline that physicians can use to say what the average number of blood units are actually used doing specific surgical procedures. So usually the facility will come up with this, or they'll use kind of a generic version of it. So usually it's like a team of physicians that will, and pathologists that will kind of oversee this. And so they may say something, let's just say for a cardiac open heart surgery that they would do right off the bat, their standard order would be 4 units. So you would, that's kind of their standard blood order, is to order a cross match for 4 units as part of that pre-surgery workup. Maybe your orthopedics, some of your orthopedics would get just a type and screen so that you would have it available if something arises. You've got a tube on hand, but you're not really setting up units for that patient. Or maybe if it's a hip surgery that they know that it's going to be, you know, a larger opening or a more complicated, then maybe they'll do it for 2 units. So whatever your facility comes up with, it'll kind of be the guide that will be used for determining how many units will be needed for that surgery or for that procedure to have available. And then it kind of gives you an idea too, if someone's going to do autologous donations ahead of time, that kind of gives you an idea too of about how many they will need. So it just kind of gives your facility an idea for certain procedures or what is typically used for those procedures at your facility. And sometimes the blood is not actually used during surgery, it's usually post-op. So maybe the next day after the body is kind of regrouping and everything, then, you know, they could have dropped a little bit from that blood loss, you know, the surgery prior, and then, you know, within 16 hours, they're starting to see a little bit of a loss and starting to be symptomatic, so they might need the transfusion, not during surgery, but post-surgery. So just to kind of recap the type and screen procedure, so this is going to include your blood type and your antibody screen, including your RH. And you're pretty much going to get a type and screen anytime there's a possibility of a transfusion. So if there's going to be a potential for surgery, a potential for any kind of bleeding, anything, if there's a doubt, a question, you're always just going to do type and screen. It's better to have everything done and prepped and ready for the possibility of needing a unit of blood, regardless of what it is. The only thing that's going to be different from just doing a blood type and an antibody screen versus a type and screen is the fact that you're going to include that bracelet for cross-matching those units, so some sort of identifier. So the cross-match is performed on the sample if the blood is needed. So if you actually need to give a unit of blood, you're going to do it off of that uniquely identified labeled sample. And so basically your type and screen is going to be done to kind of conserve your blood inventory, because we don't want to just be giving out random units whenever, wherever. But I just kind of want to mention to these blood bank bracelets. So when you're doing a type and screen for the potential of a cross match, you're going to include some kind of bracelet. Now, I've seen a variety of bracelets that look different as far as how they're manufactured or made or whatnot. Most bracelets will look something like this one down here at the bottom. So your patient information would go up here, like your name, MR number, phlebotomist, your date and time that you're collecting it, so your date and time would go on there, whatever that is, and as well as your initials for the phlebotomist. They're going to go over on that bracelet, and typically there's some sort of sticker or something that will peel up, and then that will go on the tube that has this unique identifier as well. And then you're actually going to get a strip of these numbers that will come with that tube, so that anytime you cross-match an actual product, you would actually peel up one of these barcoded stickers here and put on that unit of blood as that extra identifier. And then that allows you to actually do the barcoding. So the nurses could, if you've got computer cross matches and things like that, they're going to do the barcoding once they get ready to issue that unit. So they'll barcode that bracelet on that patient and then barcode that unit number as well, making sure everything matches. You can sometimes have those blood bank bracelets or identifiers or whatever you want to call them. Could be like in a sheet form where you would peel off the actual label wherever it's at. I think on here it's here. I think this is where you would put your Avery label from your patient or whatnot, or possibly your label that's in your computer system. So if it prints off a particular label for the test, maybe your test label goes here that's got the barcode on it. And maybe this is your label that goes on the patient. It's kind of hard for me to zoom in, and I've never worked with this brand, so I'm not familiar with it. There's just one that I could find an image of. And so, but then the individual labels would go on the unit of blood, and of course they would want to match that up. So this would be an additional label to what is already, or a bracelet or identifier that's already on the patient. So typically most patients have some kind of hospital identifier, and this would be an additional to that. So it'd be unique to blood bank itself. So some additional scenarios that could come up as far as trying to determine how to do the cross-matching for these particular scenarios would include autologous blood. So the facility that you're at should have some sort of policy and procedures into place, even stating as to if they're actually going to allow any sort of autologous donations at that facility, and then what to do with it beyond that point. And you have to have a particular spot designated for those autologous units, because you cannot mix those in with your regular units and accidentally give that autologous donation to another patient that's in your facility. So you have to have something in place to be able to actually separate that and monitor it throughout that entire process. And then your facility will also have a policy as to whether or not you'll do a full cross match on that patient as well, just depending on the scenario and situation. Now, if you have an infant younger than 4 months of age, of course, you're going to do the ABO and RH. Serum testing is not necessary, and this is because, as you recall, babies have mom's antibodies for those first few months of life. So really what you should do is do an antibody screen on mom. And again, I just want to kind of make note here to make sure, if you run into a scenario like this, that you are requesting the sample be collected from the birth mother. You have situations now where children are being adopted or being raised by aunts and uncles or other family members, grandparents. So be very specific that that sample has to come from the birth mother, the biological birth mother. If an antibody is present, then of course you will give antigen negative units honoring that particular antibody. More than likely it is mom's antibody, although you may have some situations where babies have started developing their own. For non-red blood cell products, for your fresh frozen plasma, your platelets, cryoprecipitate, they do not need to be cross-matched because you're given ABO compatible. If you have situations like your pherese platelets or granulocytes, I've actually seen pooled platelets like this. Occasionally you can get some extra red cells in those pooled platelets, just when they're making the individual platelets. So if you have a product like that that contains more than 2 mL of red blood cells, then you would need to actually do a cross match to match those up specifically, simply because you are introducing some of those red cells into the actual recipient.